Hi there. I have 23 test questions for you on the psychiatric aspects of anxiety. Ready? Let's learn psych fast. Question 1. Which of the following beta blockers is frequently used off-label for the management of performance anxiety, also called stage fright? Is it A, propranolol, B, atenolol, C, metoprolol, or D, bisoprolol? Answer A, propranolol. Propranolol, it is a non-selective beta blocker that crosses the blood-brain barrier, commonly used off-labeled to manage performance anxiety such as stage fright without affecting cognitive function. Beta blockers work by blocking the effect of adrenaline, reducing symptoms associated with anxiety, such as trembling and palpitations. It's often used for performance anxiety due to its ability to reduce symptoms like a rapid heartbeat and trembling. The other options, B, C, and D, atenolol, metoprolol, and bisoprolol, are beta blockers as well, but they're more cardioselective and has a reduced ability to cross the blood-brain barrier compared to propranolol can. Atenolol, it may actually help with physical symptoms, but it may not be as effective for anxiety associated with the performance. So in summary, propranolol is the preferred medication in situations where rapid relief from physical symptoms of anxiety is desired, making it a suitable choice for managing performance anxiety. Question 2. What is the recommended time over which anti-anxiety medications must be gradually tapered before discontinuation? Is it A, 1 week, B, 1 month, C, 6 months, or D, 1 year? Answer B, 1 month. So it is advisable to undergo medication withdrawal under the guidance of a healthcare professional. Typically what we want to do is we want that withdrawal process to span over 4 weeks and involve a gradual decrease in dosage with extended intervals between medication administrations. A week interval is insufficient for discontinuing an anti-anxiety medication therapy, while a period of 6 months to a year is excessive for such a cessation. Question 3. Which is a benzodiazepine of choice when treating anxiety associated with alcohol withdrawal? Is it A, chlordiazepoxide, B, oxazepam, C, Valium, or D, clorazepate? The answer is B, oxazepam. So oxazepam and lorazepam are both preferred medications for addressing anxiety disorders due to their lack of active metabolites. When it comes to anxiety linked to alcohol withdrawal, chlordiazepoxide and clorazepate are not recommended choices. Additionally, it's worth noting that diazepam hasn't really been extensively studied as oxazepam in treating patients with impaired hepatic function. Question 4. Which of the following classes is effective in treating patients with generalized anxiety disorder? Is it A, TCAs, B, MAOIs, C, SNRIs, or D, antipsychotics? All right, the correct answer is C, SNRIs. All right, let's break this down. So, generalized anxiety disorder, often it responds well to medications that tweak the level of the certain neurotransmitters in the brain. SNRIs like venlafaxine and duloxetine fit the bill here. They boost the levels of serotonin and norepinephrine while help to regulate mood and alleviate anxiety. Now let's look at the other options that were presented. A was TCIAs. While they can work for some anxiety disorder, they're not typically the first choice for generalized anxiety disorder due to their side effect profile. Option B, MAOIs, again, effective for some anxiety disorders, but due to the dietary restrictions and potential side effects, they're often just reserved for cases where other medications haven't worked. Then with option D, antipsychotics, these are generally not go-to for GAD. They may be considered if other options fail, but again, they're not the primary choice. So in the realm of treating GAD, generalized anxiety disorder, SNRIs take the spotlight for their efficacy and tolerability. Question 5. Which patient is most likely to respond quickly to an anti-anxiety therapy with benzodiazepines? A patient with a history of long-term anxiety. B, patient with recent anxiety reactions. C, patient with severe depression in addition to being anxious. Or D, patient with incidents of auditory hallucinations. The answer is B. Patients with anxiety reactions to recent events and those with treatable medical illnesses that induces anxiety respond most readily to benzodiazepine therapy. Long-term anxiety is best treated with medications other than benzos, such as prescription medications such as Zoloft, Paxil, Prozac, Effexor, and Wellbutrin. Severe depression does not improve with the treatment of a benzodiazepine. Patients who have psychotic symptoms do not respond to benzodiazepines either. Question 6. Since it can take some time for effective antidepressant drugs to reach a therapeutic level, one strategy is to give a benzodiazepine concomitantly, then taper the benzo once the antidepressant takes effect. Which of the following benzodiazepine is not recommended for use in the elderly? Is it A, alprazolam, B, diazepam, C, oxapam, or D, lorazepam? This is a big one, so let's dive in. The correct answer is B, diazepam. Did you choose alprazolam? Well, here's the breakdown. The statement talks about a strategy involving benzodiazepines along with antidepressants, especially considering the delayed onset of the latter. Now, when it comes to the benzodiazepines in the elderly, we need to be mindful of factors like metabolism and potential side effects. Option A, alprazolam, is not the best choice for elderly due to its shorter half-life and potential for increased risk for falls and cognitive impairment. B, diazepam, not correct either. While it does have a longer half-life, making it more suitable for elderly, it's not really the best option either due to its active metabolites that can accumulate. Then there is option C, oxapam. This one is often preferred for the elderly. It has a shorter half-life and reducing the risk of accumulation. Option D, lorazepam, another suitable option for the elderly due to its intermediate half-life. So in essence, when considering benzodiazepines in the elderly, oxapam and lorazepam are generally safer choices compared to alprazolam and diazepam. You will have to use your clinical judgment specific to your patient in question and living arrangements and comorbidities to decide between diazepam or alprazolam. Question 7. What is the primary mechanism of action of SSRIs in the treatment of anxiety disorders? Is it A, GABAergic modulation, B, neuroadrenergic blockade, C, serotonergic enhancement, or D, dopaminergic stimulation? Answer? The correct answer is C, serotonergic enhancement. SSRIs, they primarily work by blocking the reuptake of serotonin in the brain. So by inhibiting the reuptake, more serotonin remains available at the synaptic cleft, leading to enhanced serotonergic transmission. This increased serotonin level is associated with mood stabilization and reduction of anxiety symptoms. So GABAergic modulation, option A, that was wrong because GABA is an inhibitory neurotransmitter, and medications that modulate GABA receptors are often used for anxiety. However, SSRIs primarily target serotonin and do not directly modulate the GABAergic system. What about option B, the neuroadrenergic blockade? Well, while some medications used for anxiety disorder, such as beta blockers, may act by blocking adrenergic activity, SSRIs specifically, again, they are the ones that target the serotonin and are not primarily focused on noradrenaline. Then lastly, option D, dopamine, it is another neurotransmitter, but SSRIs do not stimulate dopamine release. Their primary action, again, is on serotonin reuptake. So in essence, the effectiveness of SSRIs in treating anxiety disorder stems from their ability to enhance serotonergic transmission, providing a more favorable impact on mood and anxiety symptoms. Question 8. Which is the best psychotherapeutic approach to use for general anxiety disorder in patients? Is it A, individual cognitive behavioral therapy, CBT, B, group CBT, or C, interpersonal emotional processing therapy, or D, exposure-based treatments? The answer is individual cognitive behavioral therapy. So the correct answer is A. So let's break these options down so you understand the difference between them. So individual cognitive behavioral therapy is well-established and effective approach for GAD, general anxiety disorder. It focuses on identifying and modifying distorted thought patterns and behavior. What about option B? That was group cognitive behavioral therapy. It's wrong, but what is it? So group therapy can be beneficial for certain conditions, but individual therapy is generally preferred for GAD. It allows for more personalized attention and tailored interventions. Option C is incorrect, interpersonal emotional processing therapy. This option is less aligned with primary interventions for GAD. Interpersonal therapy may have its place, but it's not the first choice for GAD. And then the last option was D, exposure-based treatment. Exposure therapy is more commonly associated with conditions like specific phobias or PTSD, but not necessarily GAD. It involves more gradually exposing individuals to a feared stimuli. Question 9. Of the following classes or agents, which has or have demonstrated safety and efficacy in the long-term management of GAD? Is it A, GABA benzo, B, SSRIs, C, gabapentin, or D, all of the above? The answer is B, SSRIs. There are safety concerns and potential for tolerance dependence, which limits the use of benzodiazepines for treatment of acute anxiety symptoms. However, SSRIs are considered first-line therapy for GAD. Question 10. When considering CBT or pharmacotherapy in the treatment of GAD, which of the following statement is most accurate? A. Evidence suggests that the magnitude of benefits with pharmacotherapy for GAD is greater than associated with other anxiety disorders. Or B. CBT requires a larger time commitment, but benefits are long-lasting. Or is it option C? Studies demonstrate significant benefits of providing CBT in conjunction with pharmacotherapy. Answer is B. CBT is typically needed for 16 weeks, but gives long-lasting benefits. Although the benefits of pharmacotherapy are more rapid than with CBT, evidence suggests that the magnitude of benefits is lower for persons with GAD. There is no evidence that combining CBT with pharmacotherapy offers any advantage. Question 11. Which of the following interventions by the pmhnp for a person experiencing attaque de nervos demonstrates culturally informed care? Is it A, offering brief supportive psychotherapy, B, offering a brief hospitalization, C, requesting a family member act as an interpreter, or D, offering a low-dose, short-term anxiolytic medication? Answer A, offering brief supportive psychotherapy. The literature suggests that although short-term anxiolytic medications may be offered in an emergency room setting, attaque de nervos is best treated with a brief supportive therapy by a Spanish-speaking Latino therapist. Question 12. What is true about pharmacological treatment of anxiety in older adults? A, course of treatment is generally shorter than for younger adults. B, drugs that are highly oxidized are more unpredictable than drugs that are mostly conjugated. C, the therapeutic dose of SSRIs is generally lower than for younger adults. Or D, highly lipophilic drugs have a more linear elimination in older adults. The answer is B. Drugs that are highly oxidized are more unpredictable than drugs that are mostly conjugated. So liver enzyme functioning, among many other things, diminishes as we age. So all the other statements are false. Question 13. The SSRI fluoxetine should not be prescribed for anxiety when the patient is also taking which medication? A. Linezolid, B. Simvastatin, C. Levothyroxine, or D. Gabapentin? The answer is A. Linezolid. It's used to treat certain infections and may actually increase serotonin as a result of MAOA inhibition. Thus, its use is contraindicated in patients taking fluoxetine. If linezolid must be administered, you want to discontinue fluoxetine or any other serotonergic drug immediately and monitor for CNS toxicity. Serotonergic therapy may be resumed 24 hours after the last dose of linezolid or after 5 weeks of monitoring, whichever one comes first. Question 14. You are discussing the use of Xanax with a 68-year-old patient. What statement indicates that the patient has an understanding of the drug? A. When I stop having panic attacks, I can stop taking the drug. B. This drug will calm me down in about 30 minutes after I take it. C. One dose will keep me calm for about 24 hours. Or D. I am taking an increased dose because of my age. The answer is B. This drug will calm me down in about 30 minutes after I take it. Why is that? It's because of the onset of the medication. Onset of alprazolam is about 30 minutes. The drug must be tapered after long-term use, and the duration is approximately 4 to 6 hours that it lasts. Elderly patients usually will have a reduced dose. Question 15. What anxiolytic drug would be given to a premenopausal patient who is a registered nurse planned to return to work at a hospital after anxiety is controlled? A. Xanax, B. Valium, C. Buspar, or D. Chlorazepate? Answer? Busparone. So busparone, it's a newer anxiolytic compared to the others that it does not cause any sedation or muscle relaxation. It is preferred when the patient needs to be alert, such as with driving or working as a nurse. Alprazolam, diazepam, and chlorazepate are all benzodiazepines, which cause drowsiness, sedation, depression, lethargy, confusion, and decreased mental alertness. All things are not good for that nurse while she's working. Question 16. A patient arrives at the emergency room after attempting SI by taking an entire bottle of diazepam. What antidote will you order? A. Luminol, B. Precedex, C. Flumazenil, D. Ramelteon? The answer is flumazenil, as it is an antidote to benzodiazepine overdose and is administered to reverse the effects of benzodiazepine when used for anesthesia. Phenobarbital is a barbiturate which further depresses the body functions of this patient. Dexamethasone is a new hypnotic drug used in the intensive care unit for mechanically ventilated patients. Ramelteon is also new. It's used as a hypnotic. So adverse effects of these drugs include depression and SI. Question 17. Why would you expect the patient with liver disease to receive a smaller dose of benzos? A. Excretion of drug relies on liver function. B. The drugs are metabolized extensively in the liver. C. They are lipid soluble and are distributed throughout the body. Or D. The drugs are well absorbed from the GI tract. The answer is B. The drug is well absorbed from the GI tract. So benzodiazepines are metabolized extensively in the liver. Patients with liver disease must receive a smaller dose and be monitored closely. Excretion is primarily through the urine. All the other options are true, but the fact that the benzodiazepines are metabolized in the liver explains why a patient with liver disease would require a smaller dose. Question 18. When compared to benzodiazepine, buspirone stands out as unique among anti-anxiety drugs because of what factor? A. Increased CNS depression of alcohol and other drugs. B. Lacks muscle relaxant and anticonvulsant effects. C. Causes significant physical and psychological dependence. Or D. rapidly absorbed from the GI tract and metabolized in the liver? Answer B. Buspirone, it's that newer anti-anxiety medication, and it has no sedative, anticonvulsant, or muscle relaxant properties, and its mechanism of action is unknown. However, it does reduce the signs and symptoms of anxiety without many of the central nervous system effects and severe adverse effects associated with other anxiolytic medications. Most of the anti-anxiety drugs are rapidly absorbed from the GI tract, metabolized in the liver, and have a significant drug-drug interaction with alcohol and other drugs and can result in psychological dependence. Question 19. Your patient said that they stopped their benzodiazepines abruptly. What do you assess for? A. Urinary retention and change in sexual functioning. B. Dry mouth, constipation, nausea and vomiting. C. Nausea, headache, vertigo, malaise, and nightmares. Or D. In most cases, nothing significant. The answer is C. Abrupt cessation of these drugs may lead to withdrawal symptoms characterized by nausea, headache, vertigo, malaise, and nightmares. When benzodiazepines are stopped abruptly, the likelihood of withdrawal symptoms increases with the length of time the patient took the medication. Urinary retention, change in sexual function, dry mouth, constipation, nausea, and vomiting are all common adverse effects of medications classified as benzodiazepines. Question 20. A 78-year-old female is brought to the emergency room by her daughter, who noticed her mom was complaining of confusion, seizures, and abnormal perception of movement. You review the medication bottles and suspect the patient overdosed on what medication? A. Benzodiazepine, B. Antihypertensives, C. A sedative, or D. An analgesic. Answer A. Benzodiazepine. Common manifestations of benzodiazepine toxicity include increased anxiety, psychomotor agitation, insomnia, irritability, headaches, tremor, and palpitations. Less common but more serious manifestations include confusion, abnormal perception of movement, depersonalization, psychosis, and seizures. These symptoms are not found in association with options B, C, and D. Question 21. Your elderly patient is taking a benzo. Caution should be used in this population because of what possible adverse effect? A. Acute renal failure. B. Unpredictable reactions. C. Paranoia. Or D. Hallucinations. The answer is B. Unpredictable reactions. Use of benzodiazepine with elderly or debilitated patients because of possibility of unpredictable reactions and in patients with renal or hepatic dysfunction, which may alter the metabolism and excretion of these drugs, result in direct toxicity. Dosage adjustments usually are needed for such patients. Acute renal failure, paranoia, and hallucinations are not commonly related to therapy with these medications in the elderly. Question 22. A 19-year-old patient who's suffering from panic attacks asked the GP or PCP if there is any medication he could take for his condition. Which of the following medication is likely to be the most suitable first-line choice for treating panic disorder? Is it A, lorazepam, B, diazepam, C, buspirone, or D, paroxetine? Answer D, paroxetine. SSRIs is licensed for panic disorders such as paroxetine and should be the first-line choice if pharmacological management is chosen. Aripramine and chloripramine, they're suggested as second-line agents if there's inadequate response at 12 weeks. Benzos like lorazepam and diazepam in this example and buspirone and sedating antihistamines have no place in the management of panic disorder. Cognitive behavioral therapy or drug treatment is recommended, but SSRIs are first line. If contraindicated or no response after 12 weeks, then imipramine or chloripramine should be offered. Question 23. While working in the psychiatry unit, you are taking a history from a patient with a new diagnosis of general anxiety disorder. You take a thorough past medical history. Which of the following is a risk factor for GAD development? A. Being under 20 years old. B. Atrial fibrillation. C. Being divorced or separated. Or D. Hyperthyroidism. The answer is being divorced or separated. So what are the risk factors for the development of GAD? They are being aged 35 to 54, being divorced or separated, living alone, being a lone parent. What are the protective factors then to know? Because that could be the other way the question's asked. The protective factors are being aged 16 to 24, being married or cohabiting. Having a thyroid disease or AFib may result in similar symptoms to JD, but it's not an actual risk factor for it. All right. Thanks for staying with us. Good luck on your tests. Go ahead and click on this next video. YouTube thinks this one would be of interest to you.